Pleural empyema, also known as pyothorax or purulent pleuritis, is empyema in the pleural cavity that can develop when bacteria invade the pleural space, usually in the context of a pneumonia. It is one of various kinds of pleural effusion. There are 3 stages: exudative, when there is an increase in pleural fluid with or without the presence of pus; fibrinopurulent, when fibrous septa form localized pus pockets; and the final organizing stage, when there is scarring of the pleura membranes with possible inability of the lung to expand. Simple pleural effusions occur in up to 40% of bacterial pneumonias. They are usually small and resolve with appropriate antibiotic therapy. If however an empyema develops, additional intervention is required. Epidemiology: the incidence of pleural empyema and the prevalence of specific causative microorganisms varies depending on the source of infection, the age of the patient and host immune status. Risk factors include alcoholism, drug use, HIV infection, neoplasm and pre-existent pulmonary disease. Pleural empyema was found in 0.7% of 3675 patients needing hospitalization for a community-acquired pneumonia in a recent Canadian single-center prospective study. A multi-center study from the UK including 430 adult patients with community-acquired pleural empyema found negative pleural fluid cultures in 54% of patients, Streptococcus miri group in 16%, Staphylococcus aureus in 12%, Streptococcus pneumoniae in 8%, other Streptococcus in 7% and anaerobic bacteria in 8%. Given the difficulties in culturing anaerobic bacteria, the frequency of the latter might be underestimated. The risk of empyema in children seems to be comparable to adults. Using the United States KITS unregistered trademark inpatient database, the incidence is calculated to be around 1.5% in children hospitalized for community-acquired pneumonia, although percentages up to 30% have been reported in individual hospitals, a difference which may be explained by an transient endemic of highly invasive serotype or overdiagnosis of small parapneumonic effusions. The distribution of causative organisms does differ greatly from that in adults. In an analysis of 78 children with community-acquired pleural empyema, no microorganism was found in 27% of patients, Streptococcus pneumoniae in 51%, Streptococcus pyogenes in 9% and Staphylococcus aureus in 8%. Although pneumococcal vaccination dramatically decreased the incidence of pneumonia in children, it did not have this effect on the incidence of complicated pneumonia. It has been shown that the incidence of empyema in children was already on the rise at the end of the 20th century, and that the widespread use of pneumococcal vaccination did not slow down this trend. This might in part be explained by a change in prevalence of pneumococcal serotypes, some of which are not covered by the vaccine, as well as a rise in incidence of pneumonia caused by other Streptococcus and Staphylococcus. The incidence of empyema seems to be rising in the adult population as well, albeit at a slower rate. Symptoms: the clinical presentation of both the adult and pediatric patient with pleural empyema depends upon several factors, including the causative microorganism. Most cases present themselves in the setting of a pneumonia, although up to 1/3 of patients do not have clinical signs of pneumonia and as many as 25% of cases is associated with trauma. Typical symptoms include cough, chest pain, shortness of breath and fever. Diagnosis: the initial investigations for suspected empyema remains chest X-ray, although it cannot differentiate an empyema from uninfected parapneumonic effusion. Ultrasound must be used to confirm the presence of a pleural fluid collection and can be used to estimate the size of the effusion, differentiate between free and loculated pleural fluid and guide thoracocentesis if necessary. Chest CT and MRI do not provide additional information in most cases and should therefore not be performed routinely. The most often used golden criteria for empyema are pleural effusion with macroscopic presence of pus, a positive gram stain or culture of pleural fluid, or a pleural fluid pH under 7.2 with normal peripheral blood pH. Clinical guidelines for adult patients therefore advocate diagnostic pleural fluid aspiration in patients with pleural effusion in association with sepsis or pneumonic illness. because pleural effusion in the pediatric population is almost always parapneumonic and the need for chest tube drainage can be made on clinical grounds. British guidelines for the management of pleural infection in children do not recommend diagnostic pleural fluid sampling. Blood and sputum culture has often already been performed in the setting of community-acquired pneumonia needing hospitalization. It should however be noted that the microorganism responsible for development of empyema is not necessarily the same as the organism causing the pneumonia, especially in adults. As already mentioned before, sensitivity of pleural fluid culture is generally low, often partly due to prior administration of antibiotics. It has been shown that culture yield can be increased from 44% to 69% if pleural fluid is injected into blood culture bottles immediately after aspiration. Furthermore, diagnostic rates can be improved for specific pathogens using polymerase chain reaction or antigen detection, especially for Streptococcus pneumoniae, Streptococcus pyogenes and Staphylococcus aureus. In a study including 78 children with pleural empyema, the causative microorganism could be identified using direct culture of fresh pleural fluid in 45% of patients, with an additional 28% using PCR on pleural fluid of negative cultures. Pneumococcal antigen detection in pleural fluid samples by latex agglutination can also be useful for rapid diagnosis of pneumococcal empyema. In the previously noted study, positive and negative predictive value of pneumococcal antigen detection was 95% and 90%, respectively. However, despite the additional diagnostic value of these tests, PCR and antigen detection have limited value in determining treatment choice because of the lack of information on antibiotic resistance. Treatment equals pleural fluid drainage equals proven empyema is an indication for prompt chest tube drainage. This has been shown to improve resolution of the infection and shorten hospital admission. Data from a meta-analysis has shown that a pleural fluid pH of